So the purpose of today's talk is to tell you a little bit about the clinical characteristics of the disease, what it is, how it affects young adults, why it's so aggressive. We're still trying to figure it out, but I'm going to tell you what it is, the etiology and the risk factors, what we've learned so far on these, and if there's any genetic susceptibility for an aggressive disease or for an aggressive inflammatory response, and I'll tell you why that is, that we wanted to answer that question. And then where are we going with this project, but also where are we going with research in dentistry. So I'm going to give you a little bit of overview of dentistry, where we stand right now, and where we intend to go, what are our potential, and what we want to do. So aggressive periodontitis disease, this project started with a call from one of the health departments in North Florida while I was at UF. And they called us, the health department director called us, our students, our DMD students do rotations on this health department. And they called our Perio division chief department chair and said, we have some cases of aggressive periodontitis in children, or used to be called juvenile periodontitis or prepubertal periodontitis, and we don't know what to do. Can you come and teach us how to do surgery? And he's like, what? Okay, let me go take a look at these cases. So he gathered a team of me as a young investigator at that time. He was back in 2006 when I just joined the department full time, out of my postdoc, and then he grabbed Dr. Magnuson, who was a big researcher in microbiology and periodontitis. So we went there to this Tallahassee clinic in North Florida, and we saw over 15 cases of X-rays cases that had this amazing disease, which is very rare in adolescents and juveniles, even young kids on baby teeth. And we were like, how are you seeing all these cases? Because this disease is very, very rare. So this is an African American, and you can tell by the racial pigmentation of the gums, Russian American. A little bit of malocclusion, the teeth are not perfectly in line, but that's not a lot of signs of inflammation. But when you look at the x-rays, and I hope you appreciate, this is normal bone levels here, and this is the level of bone going all the way to the apex, or the end of the root of that tooth. So that tooth now is starting to be mobile. Same thing with this one, and that's why it's kind of coming out of its normal alignment, because you lost a lot of bone. You can see the bone is going all the way down here, if you can appreciate this. And meanwhile, the tooth right next to it, no bone loss. You see the bone loss is over here and here. So I'm trying to explain it to you so you understand the dental view of things. So this disease is more common in the form of chronic disease. It affects a very large number of the population. 1 out of 2 Americans have chronic periodontal disease, which is gum inflammation and bone loss around teeth. However, these kind of disease, very aggressive towards very specific teeth in the mouth, which happens to be incisors, and in this particular kid, only one incisor on the bottom and one incisor on the top, and the first molars, which is the big tooth in the back. First molars, you can appreciate the amount of bone loss in the mesial here, a little bit on the distal starting on this one, and this one all the way to the apex on this side here. Can you see that? And then on this one on the other side also, very much around those first molars and a few incisors. Now, why does it do that? We don't know. Why does it affect young kids? And it's not very common, and it's much more aggressive in the chronic forms, which is much more common. We also don't know. We're trying to figure it out. So it affects about anywhere from less than 1% in Caucasians all the way to 3% in African Americans in North America. The highest prevalence of this disease, about 7% in Africa. So African Americans or African descendants are the most commonly affected, and low socioeconomic status is the very, very frequently affected population. You don't find this in private practice as much. So systemically healthy, there's nothing systemically wrong with these kids. They don't have any other problems with cardiovascular or inflammatory, autoimmunity, or nothing like that we can diagnose anyway. And it affects the first molar incisor, so it's very, very associated with those few teeth in the mouth. And there are many hypotheses as to why, but we don't know exactly why. So this disease may affect primary dentition as well, baby teeth. Okay, so it may affect kids as early as 5 to 6 years of age. And so if it does, and this is a big molar, this is a permanent molar, this is a 9-year-old, and this two little guys here next to it are the primary, or the baby, first and second molars in the mouth, okay? And as you can appreciate, the bone is going, this is normal bone levels here on the distal, and if you go on the knees, you see how the bone goes down, and that's not normal bone levels. So this disease has affected this kid at 9 years of age. Now this tooth is exfoliating, but this tooth, as you can see, the normal process of exfoliation, the roots get resorbed and the permanent teeth pushes in, right? So you can see the permanent teeth here pushing it in, and the root of this guy is almost gone, and that's how the normal physiologic process of baby teeth coming out, permanent teeth coming in. However, you can see here that these roots here on the second primary molar, not ready to go yet, they're completely intact. It's not time for physiological to go down, but instead of physiological resorption of these roots, what's happening, it's a massive bone loss around this teeth. So the bone is going away, not the root, you see? So it's pathological at this point. So, and it's associated with inflammation and pocket depths, and I don't have a picture of the pocket depth, but I'll show you how we verify this disease by putting a probe in there, and when your probe goes in there, on normal teeth, it goes 1 to 2 millimeters in. You do have a little sulcus, you have to floss, by the way. But if you lost that attachment or the bone and the attachment of the gingiva and the bone, then this probe is going to go down pretty deep, like it did 8-9 millimeters here, and it'll go down on around the primary dentition as well. So it may affect permanent dentition, primary dentition. Okay, so we started with that call from Leon County, Tallahassee back in 2006. We went to see the cases. We found about 15 cases just that they pulled out of their memory. They pulled those cases for us to see. We said, we need to investigate this. So we started, we wrote an IRB. We said we're going to collect some samples to see the bacteria involved, inflammatory response. We had a diabetic researcher at UF that did inflammatory response to LPS. We said, let's use this into this population to see if they have an exacerbated response to LPS in their peripheral blood, and see if that answers some of it. So we started with Leon County in 2006. We submitted our first grant in beginning of 2007. We had some preliminary data. 2008, when we had preliminary data, we were getting ready to publish it, and we decided to send an R1 in. At that time, it was triaged. Remember that? So, and they said, you're too ambitious, because I said I was going to do it in 5 centers around Florida because I wanted to get enough people to answer my questions. And they said, that's too ambitious, and so they triaged the thing, and then we went back. I was a young investigator learning how to write grants. So we went back and we focused to just Tallahassee, and we said we're going to focus on just 50 kids to really answer this question that we started looking at an inflammatory response in specific bacteria. And they gave us a grant. That was in 2009. And then by that time, we had Duval County, Jacksonville heard about us, said, we got cases, come see us. So we included Duval County 2009. And guess what? We went all over the state of Florida and did much more than 5 centers, right? To get the kids with the disease and to answer the questions we wanted to answer. So be ambitious. Just tell NIH you're doing baby steps at a time, and that might work, okay? So we started, Jacksonville and Tallahassee were our biggest centers. Obviously, Alachua County and all the surrounding clinics around us were sending us referrals for patients with this disease. We went to every clinic and we talked about what we're doing, what we're looking for, and they would refer us cases. We went to the Panhandle, and right before I left, I was expanding the study to South Florida when we got the renewal of this grant. We started expanding the study because we wanted to tackle genetics. So we started going to South Florida because I wanted to grab in Miami and Naples. There's a lot of Hispanics population there, and I wanted to see if that was there in the Hispanics. Came to find out most of our cases in South Florida is Hispanics or Hispanics, is African Americans or Hispanic African Americans. So it is mostly on African Americans, very little in Hispanics. So what this was us in Tallahassee back in the day, and then we gathered about so far 135 families, over 135 families. So So we grabbed the diseased kids and their siblings as well, because we wanted to see there is a familial aggregation already reported for this disease, so we wanted to see the siblings and if they had the same bugs and the same inflammatory response, and we wanted to check genetic markers on them too. So we got about 190 cases of localized aggressive periodontitis, because localized to a few teeth, according to the classification, or old classification of it. We got 107 periodontal healthy siblings of these patients, and then over 200 healthy unrelated controls to age matched to be our controls. Then they had no systemic diseases, no antibiotics, no smoking in the previous 3 months prior to collection. The age anywhere from 5 to 25. So they had either disease in the primary dentition or the permanent dentition, and 99% then of African Americans. So I got one Asian in this population from the South, about half a dozen Hispanics, but they're Hispanic African Americans, but they are Hispanics, they have Hispanic background, and then I have 2 Caucasians, and then the rest is all African Americans. So the study one, our first grant objective was to define a local and systemic inflammatory response. We wanted to see how they responded to bacteria. We wanted to define the bacterial profile. Are the bugs that are really normally associated with the disease, are they there, and what else is there? Correlate the findings with the response to treatment. So we wanted to see how they responded to treatment and how that bacterial inflammatory profile changed. So, and this was our first one back in 2009. So, and in 2014, we got the renewal of this grant to expand this population and to define the role of genetics. So we wanted to see if we went for a candidate gene approach, and we wanted to see if there are specific genes associated with it. Define the role of microRNAs, and if they had anything to do with the high inflammatory response we found in the first one, and to define the role of epigenetic changes also associated with inflammatory response to bacteria. So we wanted to see if the expression, is it intrinsic or is it an expression differentiation on the inflammatory response? And I'll tell you why we wanted to tackle genetics in a second. So just to show you a few cases, a few clinical characteristics that we found that was very interesting in this disease is that this is one of our patients in Florida, in Gainesville. And she only had the distal of the 2 first molars in the bottom. That's it. All the other teeth were healthy and all the other sites were healthy, except for the very distal side of those 2 molars. And then this is her back when she was 10. So 3 years before, is it 3 years before? No, 6 years before. And this is her. I actually have one more. When 3 years before, you already could see it. And then this is all the way back to 10 years before, and you see the primary dentition already had bone loss there. In this disease, and this is retrospective of looking at x-rays on her chart. And she ended up losing those teeth sort of prematurely, and then she had a disease on the permanent dentition. She went through orthodontic treatment, so when you apply forces to those teeth, not a good thing for perio disease, it breaks down even further, and then she came to me at this stage here, and we treated her then. So, very important to notice that this was happening way back when she had primary dentition, so we started thinking about, does this disease actually start in primary dentition, or does it start in permanent dentition? And we believe it starts in primary because we found about 90% of the cases that we could go back to the primary dentition, we did find 90% of them did have signs of bone loss around the primary teeth. And we published that. I don't have the data here. I can't show you everything, but this is really interesting what we've been finding in this population. So we believe it starts early, and we may be able to prevent it. One of the first findings of the study, which triggered us to go look for genetics, is the following. We found when we stimulate the blood of the diseased kids with LPS from anaerobic bacteria, we find a higher inflammatory response of these kids. So this is the LAP kids, the kids with the disease. This is their sibling without the disease. And this is the controls without disease. So as you can see, it goes for most inflammatory cytokines here, you can see it goes on a little degree down. So highest is from LAP, a little lower for siblings, and a little lower for controls. But the funny thing is, if you look at some of these inflammatory markers, such as IL-6, you'll see that even the healthy siblings have a very high response compared to controls. And it's very comparable to their counterparts with disease. So is it just a time factor that they will develop disease, or is it not counting for all of is the inflammatory response counting for the susceptibility of disease, or is that not all of it? Okay, so we wanted to look for why are these families having a high inflammatory response to bacteria. So we did find hyperinflammatory systemic response, and we wanted to find, this was in the local tissues as well, and so we wanted to find out why it is that they have that, and if that contributes to disease. So this is in the local GCF, the gingival-clavicular fluid. So we go to the disease site, and we found that the disease sites of the kids have lots of TNF-alpha, IL-1 beta, IL-6, all of those were very, very high in disease sites, which you kind of expect because there's inflammation. And in healthy sites within those kids, nothing there, very low levels of all of it. Healthy siblings very low, healthy controls very low, except for this one sibling who happened to have these very high levels. And I said, who is this kid? And I went back to the chart, and this is the kid that developed the disease on that one site that I happened to collect a year before. He developed the disease on that site a year later. So is the inflammatory markers in the gingival clavicular fluid showing up before actual signs of disease shows up? And that's an interesting question that we obviously couldn't answer on this project because we didn't plan on doing a risk kind of thing. But then we thought we should be collecting from all sites on the siblings just in case. But we only had a few, 5, 6 siblings that developed the disease in our cohort while they were on maintenance. You have to understand they were on maintenance with us, that we saw them every 6 months, gave them a cleaning, but only 5 developed the disease, and this is one of them. So is the inflammatory markers showing up? Do they have a high inflammatory response to bacteria? So what's going on with these kids? So siblings seems to be more susceptible to disease, and that may explain the high inflammatory profile that we have as well to this disease, contribute to the disease. So what are the bacteria we find on the sites? AA, and I'm not going to say the name of AA, but it's very hard to say, but AA is normally usually associated with this disease. All the reports have shown that, and we did a homing analysis, microarray analysis on species, on several species showed up, and one of them, and the highest odds ratio for associated with disease was of AA, 2 different probes, and this Phyllophactylosis came second, being a sort of not a new bug, but sort of not reported before, and we reported back in 2012. There's been a couple other studies now that show the importance of Phyllophactylosis as a bridge bacteria for maybe for the colonization of AA. So there are other couple studies that show that as well. So how do we treat this disease, and what happens to these inflammatory response in the bacterial profile after the treatment, right? So we treat this disease like we treat every other periodontal disease. We do mechanical debridement of the biofilm. We disrupt the biofilm. We break the biofilm. We remove calculus if there is. There's very little calculus to remove on this kids, not a lot, but there's biofilm. We break it. We use ultrasonics. We use hand scalers. And then we remove the biofilm, and then for aggressive periodontitis, not for chronic, but for aggressive periodontitis, we usually do systemic antibiotics because it's a very aggressive disease, and it shows to be show better results when we do antibiotics associated with the mechanical disruption. So when we do antibiotics, we use amoxicillin metronidazole. We adjust the dose for little kids, and we do it only for a week. Okay, so 3 times a day, only for a week, and they show very, very good response to treatment this way. So not much cases, there's not much to remove out of the pockets. It's mostly just biofilm, not a lot of calculus, which is a common finding in this disease. And the pocket depths, how we measure the disease breakdown, the pocket depths go down after treatment and all the way to 5 years follow-up. So this is 24 months, and then we do a yearly follow-up after that, up to 5 years. And we show that there's a lot of good stability of the disease. Clinical attachment levels, which measures, it's from the end of the crown all the way to the bone level loss. we showed that there's a big reduction of clinical attachment losses and all the way down to less than 1 on average, and that stays pretty stable. And we only do antibiotics at baseline. We only do 1 treatment with the antibiotics. After that, we do maintenance. You know, when your dentist tells you to come back for cleaning, that's what we do. Come back for cleaning 3 to 6 months, and we just do maintenance to keep that biofilm kind of under control, and we don't do any antibiotics after that. And this is the percent affected sites. So you notice that only 12 to 14% of affected sites in the mouth. So it's a very localized disease. The breakdown is only a few teeth, like I told you, and it goes down to less than 1% affected sites, all the way to 5 years follow-up. And that, when we call affected sites, is disease sites with the disease, right? So it does show reduction of the disease, and these are my one of our residents, Perio residents, that worked on that data, and one of my research assistants that ended up going to dental school at Florida and graduated last year, that worked on this data. So this is what it shows up. I told you there's not a lot of clinical inflammation in this disease. In 99% of the cases, we had 2 kids that had clinical hyperplasia, or inflammation of the gums, or the gums being very bulky and inflamed. Only 2 of those showed those inflammatory clinical signs of inflammatory response, and this is one of them. So it's nice to see that gets reduced a lot after treatment. Both of our cases of hyperplasia show complete reduction of hyperplasia, and these are the bleeding indexes, the pocket depths, the pockets over 4 reduction, and the pockets over 4 with bleeding reductions through time. And this is her bone levels, left side of the mouth. You see a little bit here and a lot here, right? And this is after treatment. You can see the bone is kind of regenerating, which doesn't normally happen on chronic periodontal disease. So if you have chronic periodontal disease and your dentist says you can't get the bone back, he's telling you the truth. But in aggressive perio for young individuals, this bone may come back, and it's a very frequent finding for us in this population. And this is without surgery. A lot of the times we do surgery in these cases to put bone grafting. This is without surgery. This is the right side of the mouth. You can appreciate the amount of bone loss here, and then the recovery 24 months after treatment. And I had the interior too, but I didn't show that. So what happens to the inflammatory response after treatment? Well, once you treat this disease, apparently the inflammatory response does go down after treatment, as Patricia came as a postdoc from Brazil, and she worked on the data. She looked at the levels of several inflammatory cytokines go down after treatment. You can appreciate the amount of standard deviations in this population. Some are very low to begin with, some are very high to begin with, and they go down, and some go down and up after some time. And it would be nice to see if there's any correlations to treatment on this. And I will show you what we found in correlations to treatment. Naveen was one of our undergraduate students that started working in this data. He got into dental school at UF, and he actually helped me publish this paper. Back in 2016, we compared the people that are very high responders versus the low responders at baseline before treatment, and he found that people that are very high in some of the inflammatory cytokines tended to respond a little slower. They responded to treatment just a little slower. You can see that. And people that were low for all cytokines in the beginning, they were very low responders, we call it. They responded with a dramatic response right at 3 months, and they kept it all the way to 12 months. So there's a differentiation in the response to treatment depending on their initial inflammatory response to bacterial LPS stimulation. So we thought that was very interesting to know that not only it might dictate the initiation of disease, but it also may dictate how they respond to treatment. So what happens to AA after treatment? The one bug that was the highest odds ratio associated with this disease does go down after treatment. This is disease sites, and this is healthy sites. You can appreciate the healthy sites don't have a lot of AA. Disease sites have about 80% of AA presence. It goes down to almost 0. It tries to rebound a little bit at 6 months, but it goes back down to all the way to 24 months. And guess what? To undetectable levels after 12 months. We cannot detect AA again after 12 months, at least on this population that we did. It's about 50, 60 kids here. And then this is apoptosis, also goes down after treatment, tries to rebound, still goes down. Did I do any other treatment here? No. I just did systemic antibiotics right in the beginning with disruption, and I kept them on maintenance, and somehow the bacterial profile changed and maintained very stable after that. And I have bacterial profile pictures, but I didn't have time to show you all, but it changes, the bacterial profile changes after treatment. And these are my amazing collaborators for the genetic studies. So we had a PhD student at Florida working on this data. He specifically honed in into one of the candidate genes, the P2RX7 is an inflammatory gene that he was interested in. So he helped us with this whole data. Peggy Wallace is my collaborator at UF. And then when I came to Kentucky, Jim Hartsfield and Lori Morford are helping with figuring out the genetics into this population and how it associates to the disease. We found out of 13 genes that we specifically tested, those genes are all associated with either the TLR pathway, associated with chronic inflammatory diseases, or previously associated with periodontitis in other studies. We tested them, and specifically 24 SNPs in those, and we found lactoferrin gene be very, very highly associated with this disease phenotype, even after multiple corrections. IL-1 beta came out too, and these are all the ones that were significant associated after corrections. IL-1 beta diplotype and the TLR, the toll-like receptor 2, which is associated with that responsiveness I told you about. We tested that, and one of the diplotypes came up, and IL-6 came up as a pro-inflammatory one too. So there's more to come on the genetics and what it means. There are other studies that look at lactoferrin gene and how it associated with neutrophil response, and I think that there's more to study on those and mechanistically why those genes are associated with the disease. Interestingly, we looked at the inflammatory profile, the inflammatory response profile of these kids, and we tried to associate a specific inflammatory profile with genes, and we found 3 of these genes associated still with this inflammatory profile. Now, whether it's directly correlated or not, we don't know yet, so we're still honing out on the genetics and what it means for the inflammatory response of these kids and to this disease. So we're still going on with this. Amanda, also a DMD student at UF, she looked at methylation, DNA methylation, which is the third aim of our grant renewal, and we looked at DNA methylation of specific genes in the toll-like receptor pathway to trying to find out if there is the methylation is associated with inflammatory response, and we found that severe periodontitis kids showed a very hypomethylation of some of these genes, like MAPK3 and MINE88, which are inflammatory genes in this cascade, and it's different from the moderate severely disease, and it's different than controls. So even the different stages of the disease show a different methylation pattern for the expression of those genes, and so we think that the activity of the disease changes also the epigenetic profile of certain genes that may change the expression of these cytokines depending on the stage of the disease they are in. So this is very important data that we published. Amanda went for the Human Presence Award, and she went for the hat competition all the way to the finalist. She was very excited about that. Today she's doing a GPR program in Florida. Fantastic student. So, and these also, the methylation levels of these genes also associated with high inflammatory response as well. So we just don't understand why the different stages of the disease are showing different activities of the methylation status, which is very interesting because the activity of the disease, they go through phases of breakdown and quiescence and breakdown and quiescence. So it makes you think, are they going through breakdown, 3 moderate stages, and they get to that quiet phase afterwards? Is that why? We don't know that yet, so we're still investigating that. So basically what we're looking at is that there's specific bacteria involved with the disease, the specific inflammatory profiles. The LPS of these anaerobic bacteria are having a significant inflammatory response from the host, and this may be contributing to the continuous breakdown or the aggressiveness of the breakdown of the disease locally. One thing was still figuring out is how is the genetic and the epigenetic factors may influence that host responsiveness, or if there's a bacterial profile that will trigger that. We're still investigating this. So how do we put all this together, right? We have genetic data, we have epigenetic data, we have how the host responds and the inflammatory response, and we have specific bacteria. So we're trying now, one of our carryover funding projects is on putting all this data together to try to find a network approach that will try to put the genetics data to explain some of the inflammatory data and so forth, and how it dictates disease breakdown or disease severity on these kids. So this team, we put Dr. Nagaharan, Radha, it's easier, is helping us, the bioinformatic team, Hunter Mosley is helping us with the bioinformatics now for this grant, and then Dr. Morford and Jim and Peggy Wallace is on the genetic side. We're going to try to put all this data together and try to make sense of it. Is there a specific inflammatory genetic profile that will make this kids more susceptible to the disease? And is there a specific genetic inflammatory profile on the siblings to kind of explain why they're more susceptible for this disease, or if they are more susceptible for the breakdown? So that's what we're trying to put it all together now on our new initiative. So what are the next steps? We are going to get more people now. So now we expanded to Florida. So the next step was to expand through other parts of the country and then outside. So what we want to do is that we know the bacterial profile may differentiate in different populations with aggressive periodontitis. With some reports we have in the literature, now does the genetic profile of these kids, is there a specific genetic profile, and is there a specific genetic profile in different parts of the country? So we have connections with UK, Africa, and South America, and we're going to try to get families with this disease and without, and then we're going to try to do exome sequencing, home down and specific genes, and hopefully associate this gene with a specific inflammatory response in the future, and try to figure it out, is there a genetic component to this, or is there other environmental factors? So that's coming up, and that's where we want to go with this particular study. Now let me tell you a little bit about what's going on in dentistry. This is a new thing for me. This, as Vicki said, I just joined as an ADR in July, so I'm still learning a lot about what the college is doing, but I see a lot of potential in the college and lots of potential for growth. Okay, so let me tell you a little bit about dentistry. We are one out of 5 schools in the U.S. with digital dentistry, digital dentistry curriculum. What that means is that we invested, our previous dean invested a lot of resources into making our school very tech fancy and progressive in that sense. So we're happy about that. The students are excited about not doing alginate molding anymore. Who likes alginate molding here? Raise your hand. That's right, I didn't like it when I was in school. And so now we're scanning things and making crowns. So this is a very exciting time for us. UKCD started in 1962 with only 25 students per class. Today we graduate 65 on average DMD students each year, and 21 students in different specialties. We have oral maxillofacial surgery, 3 each year graduate from there. Periodontology, we have that specialty, 3 graduates from there every year. Orthodontics, 3. Oral facial pain, we got 2 to 3 a year. We have a graduate practice residency program, a general practice residency program, which is a more specialized residency. We have 6 every year in the Kentucky Clinic, and then we have the pedo program also in the Kentucky Clinic, and we graduate 4 pedodentists every year. We have about 68 full-time faculty, 115 total, counting the part-times, and we have newly renovated clinic. So we're very happy with that, with the digital dentistry on it. So we got about 4 clinics. We have our UK dental building, where most of our DMD students, most of our education go in for our DMD students, and most of our residency. In the Kentucky clinic, like I said, we have the GPR program, the Perio, and the orofacial pain clinics, and we have Turfing Clinic, where our dentists also practice. We have about 150K patient visits in the fiscal year of 2018. DMD clinics, the student clinics alone, saw about 7,000 patients last year alone. So we do a lot of service to our population in Kentucky, in Lexington, and outside. So we have outreach programs in the whole state of Kentucky. All the blue dots means that we either have fixed dental clinics or dental outreach programs that is funded, part of it's funded by the Kentucky Block Grant, and we are able to, we have mobile vans that go to schools, or we have fixed clinics on these areas in Western Kentucky and some Eastern Kentucky and some here in partnership with the Health First Bluegrass. So I'm learning a lot about these, how they are run, and I see a lot of potential for us to make those amazing outreach programs a very good resource for research in the future. So we serve several counties in the UK. This is one of our clinics in Marshall County, Benton. We have our Delta Dental Kentucky Research Center. So it's a clinical research, it's a beautiful clinical research facility. We have some of our staffs here that can tell you all about it. We run studies there, and I'm going to tell you, we're running a diabetes periodontal connection study over there right now, and we intend to populate this and increase the utilization of this clinic. We have great facility there for that. And we have our Center for Oral Health Research is where house most of our core labs and most of our faculty, for our research faculty. So our mission is to foster quality and innovative research to ultimately support state-of-the-art and evidence-based patient care, because that's all we do, these things to better the patient care of our population, better the oral health of our population, and we want it to be evidence-based. And we want to lead UKCD research towards national and international recognition. That's our mission. We recently formed an advisory committee that helped me come up with this mission, and some of the members are here, and I fully intend to get them fully involved in our strategic planning moving forward to make our research grow. How are we going to do this? I believe in team science approach. I don't think we can do, I think we can do great science by ourselves, but I think we can do excellent science when we partner with other brains or other expertise, right? And so I think fostering collaborative work within and outside of UK, we have amazing researchers and centers at UK that we can tap into, and I fully believe in that collaborative work for us to lead to success of our enterprise. So aligning NIH strategic planning to our own potential is a must. So we want to see what is NIDCR, the National Institutes of Dental Craniofacial Research wants to fund, what are their areas of priority, and how do we align to our own potential to get successful grant funding so we can do our better and greater science. Protecting time of our faculty to accomplish these goals is very important. Increased research force within UKCD is a must. We have about a third of our faculty is 28 faculty and with a 10% research DOE, but only 6 of them have over 30% distribution of effort for research. So what that means is that most of our faculty that have any research have very little time for research, and they're mostly overwhelmed with the clinical activities that we do because we have to do the clinical activities. So most of our faculty are associated with clinical activities, and so how do we protect their little time to do meaningful research, and how do we increase the faculty that are doing meaningful research, and for meaningful research you need a little bit of time. So that's one of the things that we want to hone or work on. We need for all this, we need a well-structured plan, realistic goals, and correct outcome measurements to make sure we're working in the right direction on this. So we have our REC meetings going on every month, and and they're helping me come up with a strategic plan at this moment to get to these goals here that we want to get to. So we have amazing potential. We have people doing oral-systemic connections, and in this group we have connections with the Diabetes Center. We have Dr. Miller doing some diabetes research. We have Dr. Dolph in connection with Barb Nikolajczyk over diabetes, doing Perio and diabetes research. And we have initiatives on oral infection and cardiovascular disease risk, which is very important, and we have some initiatives on the area as well. We have a group doing aging, inflammation, and microbiology. Other than me, we have Dr. Gonzalez. He's doing something in aging, periodontal disease mechanisms of inflammation, connection with medicine. The Aging Center is a hopeful connection we do in the future for this. Microimmunology, Dr. Gonzalez already has a collaboration with pharmacy coming out now. Hopefully it will get funded for cool use of therapies against inflammation and bacteria. And we have also potential for collaboration with engineering in fighting periodontal disease, and I'll tell you more about it. We have oral cancer initiatives. We have the Eradicate Oral Cancer, funded by the United Health Foundation, that's looking at the screens of several people for early detection of oral cancer, and we have a potential there to do some research. I'd love to do that. We have the block grants that help us with the outreach programs out in the skirts of Kentucky State, and we hope to get this infused with research at one point. The Ryan White Foundation helps our helps us take care of HIV patients, and we hope we can get some research in that area as well. Collaborations with Marquee, some are on the way. The Center for Health Equity Transformation, collaborations with that center has to happen if we were to expand those outreach programs into research. And CCTS. So I'm hoping to pick the brains of CCTS to make it all happen. So our case in public health, we have the genetics group. Oh, and then we have the Eradicate Caries Initiative out of Kentucky Blue First Health Department, and we're going to get that started soon. We have a little pilot funding for that, and we hope to get some meaningful results out of that too. We have a good genetics group that study specific malocclusion, crooked teeth, right? Dental agenesis, which is missing specific teeth with genetic markers, and cancer, and how they relate. So we have good initiatives on this area with Dr. Hartsfield and Morford, and apparently they were planning on a multi-center study too, and so we're excited about that. We have our collaborations with public health initiatives will hopefully enable more individuals to study genetics a little bit better. As I mentioned to you in our own study, we want to do that. And other institutions is going to be very important for genetic studies to mean anything, right? We do have plans to do a biobank at UKCD, which might boost all of these areas for clinical and genetics research. And we are talking to, I talked to Kenneth about their CCTS biobank, and we want to kind of mimic what they were doing and try to do something meaningful for our school as well. So this is going to take time, but that would be very helpful for clinical and translational science in the future. We have an amazing orofacial pain group. It's nationally and internationally recognized. And then we have some research in orofacial pain going on right now. We got COBRI and Ignite research collaborative efforts in finding out genetics, microarray expression. Dr. Dana here is here to tell you all about that. And we have associated with pain mechanisms, right? And we have a we're looking into candidates to boost this area as well. And I see a lot of potential collaborations with behavior science, psychology, and physiology into the mechanisms of pain. So this is just a very broad idea of what we're doing right now. Dental materials is another thing that we're working on. It's a new initiative. Dr. Roberts and myself, and there's a resident in ortho that's doing collaborative research with engineering for in the use of scaffolds and nanoparticles for either tissue regeneration or against periodontal inflammation. And so we're excited about these new initiatives that are coming up, and we'll hopefully give you more news on that in the future, how that's going. But we are exciting collaboration with engineering right now. So if you look at NIDCR priority areas, we are all over them. We are over oral health and overall health. We got our diabetes systemic initiatives that is right there. Precision oral health with our genetics work. Regenerative medicine with our collaborations with engineering, and our health disparities potential with all this outreach programs we have. We have amazing potential to do health disparities research and so for diverse workforce around the state. So we are very capable of reaching all these areas of NIDCR strategic planning, and this is just to tell you how Kentucky is lacking in Medicaid dentists that have access to give access of care or dental care to this rural population in Western Kentucky. You can see that's a big area of need in Western Kentucky, and we have outreach programs right there, and so there's a lot we can do for Kentucky. And as you know, Kentucky is no good in obesity, cardiovascular diabetes, and smoking rates, which are all associated with periodontal disease, oral cancer, and oral pain and inflammation, with the mental health distress and physical distress in the country being so high, in the Kentucky rates being so high in that just contributes to our potential of saying this is a problem in Kentucky, this affects oral health, how do we go about it? We have tremendous potential there. So just to let you know, we are number 24 in number of dentists per 100,000 patients out there. So we're not bad in number of dentists, and we were the first state in the percentage of people who receive fluoride water, which is, preventive against cavities, right? But we are still the 10th in the nation with high rates of not visiting a dentist in the previous year. We are in the top 10 with higher rates of permanent teeth extracted due to decay or periodontal disease. Periodontal disease affects 45% of Kentuckians. Second in oral health cancer rates in the country. So we still have lots to do, and we still have a lot of potential to help Kentucky oral health to improve through research. Particular populations that are affected with these rates are children and adults from lower socioeconomic status. There's the potential for health disparities research, elderly, and pregnant women, believe it or not. And then just 52% of our 5 and 6-year-old students entering public school had documented dental screening, even though it is health. Like everybody has kids in public school will know that it's a mandate. They have to have dental screening in order to enroll in public school, but only 50% of them had really followed up with it. So some things we're working on very briefly. We have our research committee formed we intend to do an internal review of grants coming out the door, and we're working on strategic planning right now to see how we grow and what areas we can grow better. We're doing core lab and space restructuring. We're doing partnerships with medical school engineering, CCTS, biostatistics, and public health, like I told you about. We're doing some of these initiatives. We are assessing potential for new research candidates. We need to increase our research force within the school for sure, with meaningful research effort. Programs, we are working on a DMD research track structure program. We already had something in place. We are better structuring that to give meaningful research experience to our dental students that want to do this in collaboration with CCTS ICR course with Peter. And the PhD program in partnership with IBS, we're working on this right now, and this is a great potential for to increase our research potential as well. Internal funding for pilot studies has just came out. We got 6 applications, we'll fund 4 of those. And we have student fellowships for those who wants to do research. They have a little boost to do that. We got new RRC funding for massage therapy and facial pain, like I mentioned. We have a Kentucky block grant that funds our sealant programs in schools and some of our outreach programs. We have some carryover from the COBRA grant. We had a big COBRA grant for the last 15 years. It's just ended. And so now we have some carryover pilot fundings for 2 of our investigators and 1 in medicine to carry on the work for bigger fundings in the future. We have 2 R1 submitted this past cycle dealing with inflammation, periodontal disease, and disease prevention via focused education. Those are the 2 ones submitted. We have 3 R21s just submitted, and 1 of them had to do exposure to dental personnel to blue light, those curing lights. Genetics and radiation resistance of oral cancer cells is one of them, and dental implant material with laser-driven acoustic waves. So as you can see, we have lots of good ideas coming out the door, and hopefully they will get funded soon so we can work on them. So the bottom line is there's lots to do. We have amazing people. We have an amazing university with a lot of supportive activities, centers, and other great investigations around we can tap into and get collaborative work on to make great science. So together we can, and together we will. So thank you very much. I do miss the Florida beach. However, I do love the change of colors and the snow of Kentucky. So I'm happy to be here. Thank you so much.